Thank you. Thank you. So next for the next talk, I would like to invite Dr. Vikash Talreja for a talk on PHESGO in HER2 positive breast cancer.
Very good evening to everybody. And I would really like to thank Roche for complicating the things in the previous panel and making things simple in this panel. I believe this could be the simplest thing the Roche could have done. And that could have been the worst thing that Roche could have done, adding the foundation to our daily tumor boards for such intellectually driven discussions. So thank you, chairpersons, for the kind introductions. Thank you, Dr. Mishra sir, Akhil, and the whole team of Banaras for the kind invitation and beautiful arrangements, I must say, and an academic, intellectually driven discussion so far now. I won't take your much time because I know you are between the lunch and going back safely at your homes. In a Sunday afternoon, I won't take much time, but yes, Roche has changed the way we treat breast cancer a long way back, and it has also changed the way we treat the HER2 new breast cancers, especially from the patient's perspective, the way they have come with the molecules. We all know that Perjeta Herceptin has transformed the treatment landscape and is the standard of care for patients with HER2 new positive breast cancers. We had 3 beautiful studies in the neoadjuvant, adjuvant, and metastatic. In neoadjuvant, we had Neosphere, where the addition of pertuzumab plus trastuzumab plus chemo significantly improved the pathological complete response from 31% to 49%. There were additional supporting studies of Trifina, Berenice, and Peony. In the adjuvant situation, we have the Affinity trial, where the addition of pertuzumab and Herceptin chemo reduces the risk of recurrence by 23%. Reduces the risk of death also by 23%. In those patients who are node positive, again, it reduces by the similar margin in early breast cancers. In metastatic, we all know the Cleopatra data, where the addition of pertuzumab, trastuzumab, and the chemo significantly improves the median progression-free survival from 12.4 months to 18.5 months. And the overall survival, we have seen unparalleled, being reached up to 5 years, that is median OS of 56.5 months in a metastatic HER2 new positive breast cancers. So it has been a standard of care across guidelines and across various platforms. And as you could see, that's how the patient experiences their journey. It is always multidisciplinary, collaborative approach, where you look at the patient. When it's T1 lesion, you go ahead with the surgery. Anything which is more than or equal to 2 or node positive, induction chemo plus targeted agents, trastuzumab, pertuzumab. And you look at the pathological complete response, whether if it's a pathological complete response, again, continue what you started in the neoadjuvant, pertuzumab, trastuzumab based regimens. And if it's some residual disease, you change your gears to TDM1. Now, surgery, again, we have, if a pathological complete response, trastuzumab plus paclitaxel. If there is a node positive disease, pertuzumab, trastuzumab based regimens is there. Now, all these patients, as you see, when you discuss them first day that you have to take the infusions, it is difficult for them to get convinced. So there are long infusion times, observation time, as well as congestions at clinics and hospitals. Pertuzumab takes at least 60 minutes, followed by observation of at least 30 to 60 minutes. Trastuzumab again takes 30 to 90 minutes, depending upon the loading or the maintenance dose you are trying, and observation for around 2 hours. So observation, infusion time, the resource utilization is very, very important in a resource-constrained situations like ours. Preparation time also takes longer, and therefore it is very important that we choose our resources very well. Also, when we put those indwelling catheters, whether we are using ports, we are using PICC lines, there is an increased risk of infection, thrombosis, and discomfort. Also, with venous SS, it's always difficult because it's burdensome, not only physically, but also financially for these patients, and repeated venous punctures also irritates them due course out. So PHESGO came as the first formulation in oncology to combine two monoclonal antibodies, pertuzumab and trastuzumab, in a single vial for a subcutaneous injection. It contains the same antibodies as approved for the IV pertuzumab and trastuzumab, but has a different route of administration. It is formulated through the recombinant human hyaluronidase to allow the subcutaneous administration of a higher drug volume. So 15 ml is the loading dose, 10 ml is the maintenance dose. It's a ready-to-use fixed dose formulations administered by a subcutaneous injection in the thigh approximately over 5 minutes. Now, the mechanism of action in pertuzumab and trastuzumab fixed dose is similar. It is designed to work as a dual HER2/neu blockade. In preclinical models, pertuzumab targeted a subdomain of the HER2 receptor other than the trastuzumab to block the dimerization with the HER1 and HER3 receptors and provide a dual blockade of HER2-driven signaling pathways. Hyaluronidase, on the other hand, is an endoglycosidase which increases the dispersion absorption of the co-administered drugs when administered subcutaneously. Hyaluronidase allows the subcutaneous delivery of a much larger drug volumes, increases the permeability of these subcutaneous injections by depolarization hyaluron based on the preclinical studies. And effects are reversible, and the permeability of this is restored within 24 to 48 hours. So if you look at the diagrammatic, after the subcutaneous administration, the architecture of the skin is reformed within 1 or 2 days due to the rapid clearance of the hyaluronidase and the faster hyaluron turnover. The subcutaneous layer, which contains a mixture of this hyaluron fibers and collagen fibers, it limits the volume of administration to less than 1 ml. With the introduction of this molecule, what it happens, it degrades the hyaluron at the injection site, and there is no structural change in respect to the macromolecules and collagen and elastin. With the degradation of the hyaluron, what results, there is an increased local dispersion of the molecule, enabling a larger volume of fluid to be administered safely. So this subcutaneous administration allows more than 1 ml of this fluid to be administered. This is how we usually administer. So even if you have to administer 10 ml, 10% IgG solutions without the hyaluronidase, you see the infusion, and immediately post infusion, you look at the swelling, and with the hyaluronidase infusion, you could see the swelling just doesn't occur. So the first and the foremost question that comes to our mind is subcut and IV similar? Yes, we have a pharmacokinetic efficacy and safety study. When the PHESGO was developed, the PHESGO had a recommended dose of loading as 1200 milligram pertuzumab, 600 milligram trastuzumab, and as a maintenance, the PHESGO has a 600 milligram pertuzumab and 600 milligram trastuzumab. There are PK/PD studies over it, where healthy male and female cohorts were taken, and the target subcutaneous dose was determined. And if we look at the PK dose findings, the loading dose and the maintenance dose which was used in the PHESGO were similar to those used in the development of both Herceptin subcut and MabThera subcut. And there was no new safety signals which were observed for the pertuzumab subcut alone or when co-mixed with the Herceptin subcut. And this favored the development of PHESGO. The Federica trial was a phase 3 non-inferiority study assessing the PK efficacy and safety of the subcutaneous PHESGO versus the IV pertuzumab and Herceptin. It was stratified based on the hormonal receptor status, clinical stages presentation. All patients who are operable or locally advanced inflammatory HER2 breast cancer positive patients with more than 2 centimeters or node positive stage 2-3C disease. The primary endpoint was looking at the non-inferiority of cycle 7, that is pre-dose cycle 8. The serum trough concentrations were considered, and the secondary endpoint was the non-inferiority of the cycle 7 pre-dose, that is cycle 8 trough concentrations the pathological complete response, the safety, the invasive disease-free survival, the event-free survival, the distance recurrence-free survival, and the overall survival. If we look at the PK parameters of it, they were found to be bioequivalent to it. So PK endpoints are very key focus on the subacute studies, and they were used to assess the bioequivalence. The trough concentration, what we believe are the concentrations meant at the end of a dosing interval. So it is related to the mode of action and is associated with the clinical outcomes. With the area under curve, we find out how much exposure of the during the course of the treatment cycle, as how much of a drug stays in the body and for how long. And it also correlates with the trough concentrations. The Cmax, or the maximum concentration, is not subject to distribution and elimination effects, and is subject to the most of the time the maximum concentrations that we can achieve with the drug. Now, Frederica was a non-inferior study, and it proved it to be a non-inferior based on the cycle 7 trough concentrations, which were equivalent with the IV formulations. So the lower limit of the 90% of the confidence interval of the trough concentrations exceeded the non-inferiority margin of 0.8. And similarly, the pathological complete response rate were identical, irrespective of whether the patient was underweight, overweight, obese, or was normal. The subcutaneous delta version was only 0.15%. And the rates of the treatment discontinuation were also similar. So if we look at the safety profiles, whether the ejection fractions were reduced or there were alopecia, nausea, diarrhea, and the other chemo-related side effects, it was similar with the two arms. Also, the areas of the adverse events of the interest, including the cardiac dysfunctions and the hypersensitivity, they were similar between the two arms. So there was no meaningful difference in the cardiac safety between the two arms. The ejection fraction decline and the cardiac safety was exactly similar to each other. So PHESGO showed non-inferior PK versus the IV pertuzumab, trastuzumab with an equivalent efficacy and safety, and it was showing a non-inferior serum trough concentration levels as compared to the IV concentrations. The pathological complete response rates were exactly similar, 59.7 versus 59.5% with the IV formulations. The safety profile was also similar, and no new safety signals were identified, including when switching the formulations. So looking at the patient's perspective, do they prefer the subacute version or they prefer the IV version? The Franska study was there, which assessed the similar things, and all taken into considered which method you would prefer. Most of them, as you could see, preferred the subacute version. The reason, because there was a lesser time in the clinic, more comfortable during administration. 87% of the patients choose the subacute version as compared to the IV version. And you could look at the preference, 93% had a strong or very strong or fairly strong preference to the subacute versions. And more patients were satisfied or very satisfied with the versions of the subacute, 88% as compared to 68%, because the treatment had no impact on the patient and the physician speaking time. And most patients had more than enough time to talk to their physicians during their treatment as compared to the IV treatment. Majority of the healthcare physicians also felt that switching from IV to subacute would save time and resources. If you look at the infusion time, it's less than 5 minutes. The treatment room time as compared to the IV administration, you could look at the drastic difference between 300 minutes and the subacute version of 7 to 8 minutes. And 88% of the healthcare physicians thought that the subacute was the quickest form from the start of preparation to the completion of administration. 87% of them felt that subacute required less resource use for preparation and administration. 77% of the healthcare physicians agreed or strongly agreed that the ready-to-use subacute version results in lesser drug wastage also. And adverse events before and after switching were also similar. Even if there was radiation skin injuries, injection site reactions, they were all similar in the either groups of the same. So 85% of the patient preferred subcute version as compared to the IV formulations, where only 14% preferred. The reasons being less time in clinic, more comfortable during administration, more patients getting satisfied, more patients, including that the treatment had no impact on the amount of the time they had to talk to their nurse or the doctor while receiving the treatment, and they had more enough time to talk to their nurse and doctor. And the perception of the physician is also in terms of the time savings, fewer resources, and the same safety signals. If we have to look at the safety profile, we have good studies to corroborate with it. So what are the practical considerations for using in the real world? It's a very simple formulation. You ask the patient to sit back, relax. Be sure to arrange your chair in a recliner so that the patient's feet are flat and you're able to sit up straight without twisting, bending, or reaching to administer the injections. And also, we ask them to be very, very comfortable in their positions. Never ever administer the subcute version in the abdomen. Always alternate between the left and the right thigh only. Do not split the doses between two syringes or between the two sites of the administration. Even with very slim patients, it is safe and comfortable to use. Each new injection should be given at least 2.5, that is 1 inch from the previous site, and choose an area of healthy skin that is not red, bruised, tattooed, tender, or hard. And always record where you administered the last injection. To administer, pinch the skin with your hand to create a fold. Inject and maintain the needle at an angle of about 30 degrees. Important that at first it will be difficult to start because of the thickness of the solution. You can use a butterfly needle, which makes the administration simpler. If any point during the injection, the patient feels pain, discomfort, ease of the injection before continuing. Keep the needle in place and check to sure that the needle is at about 30 degrees from the angle of injections. The injection should be slowed, paused if the patient experiences any injection-related reaction. It should be discontinued immediately if the patient experiences any hypersensitivity reactions such as anaphylaxis. Also make sure that the medications to treat those reactions and the emergency equipments are available for immediate use. After the loading dose, observe for at least 30 minutes for the signs of hypersensitivity reactions. And after the maintenance dose, you should observe at least for 15 minutes. Depending upon the hospital outpatient settings, the dose can be administered on a dedicated day.
Please stay the time.
So to conclude, PHESGO provides benefits in cost, time, and reduction of the patient and the healthcare physician burden. Shorter time of administration and observation period, has a lesser invasive method of administration, freeing patients from the burden of the IV-related pain, bruising, and irritation. Fixed dose formulations help reduces the dosing errors, reduce the time required for the drug preparation and administration, and there is no new safety signals that has been observed when switching from IV to subcute. To conclude, it is safe, it is effective, equivalent, equal pathological complete response rate, lesser, more patient preferences, lesser clinic time, more patients being happy, and more doctors being happy. And also it is guideline approved by the FDA and EMA for the same. Thank you for your patient listening. Would love to answer any questions.
Thank you, Dr. Vikas. So I believe that with PHESGO, it is easier